Sonia, are you good?
Hey, good morning, everyone. We're just gonna let people trickle in here before we get started in earnest. Good morning to all, or good afternoon, depending on where you are.
Hello, everybody. Muffin Man says hello too.
Very cute.
Muffin is always part of these discussions as a co-host.
He says very little, but contributes a lot. Excuse me.
Right, if you guys want, we can probably get started these first few slides, and then as people come in, we'll be good onto the good stuff anyway.
Okay, let me shut little phone off here. Okay. Hi, everybody. It's nice to see you guys, again. I think I've been away the last couple webinars, but I'm very glad to be back today. Today's a big subject, and we brought in our friend and colleague, Rebecca Sudore from, hi, Rebecca. Rebecca and I have known each other a long time. We work together at UCSF, where you still are, and kicking ass at UCSF. And we met, I think we really dug in together through that AHPM lead thing.
Yeah.
Yeah, I don't know how many years that was ago, but it's been a while.
Let's just not talk about that.
Okay, deal. Especially because we can't remember it. Okay, so good deal. But Rebecca is an amazing physician and researcher, and has really advanced the ball in advanced care planning. I mean, you are one of the experts. So we are really happy to have you here today. So Rebecca, why don't we just sort of jump in? But before we do, there's a little sort of logistical kind of bit here. Back to you, Sonia, real quick.
Yeah, thanks, BJ. Thanks everyone for being here. Just a quick FYI on how you can interact with us after Rebecca and BJ have kind of gone through the level setting slides. You can raise your hand and we will unmute you, and you can ask your question out loud to Rebecca or BJ. Or if you prefer to not speak out loud, you can type your question into the Q&A box and I will read it aloud for you. So either one, up to you. Raise your hand, say it out loud, or type it in, and we'll address it that way. Heads up, if we do not get to all of the questions, we will try to record a little second session or get back to you over email to address your question. But if we don't get to you here, we will figure out a way to get it addressed in some form afterwards. Thanks again for being here. And final reminder that BJ usually says, this is meant to be a safe space. There are no bad questions. There's nothing, everything is on the table here. So we hope you feel free to ask anything that's on your mind. Thanks again for being here.
Yeah, just to hammer that last one, we really mean that, guys. This is a safe place. Be kind, be honest, or just listen. But that's it. You're very welcome here, and there is no such thing as a silly question. So really let it rip. This is our opportunity to hang out with people who know stuff and talk things through. So with that, Rebecca, maybe we'll just sort of, advanced care planning has meant different things over time, and as something of a science, it's an evolution. So maybe you could sort of take us a little bit through the broad strokes of ACP, what it's looked like and what it looks like now.
Sure, but first I was actually really curious about this slide. And whether you or Sonia chose it, and maybe you could talk about it a little bit, because I was trying to work it out.
These are Sonia. We both love Francis Bacon, but Sonia gets all the props for picking the art for these things almost every time. Every time they're always Sonia's babies. So Sonia, anything you want to say about this Francis Bacon piece?
I've always loved Francis Bacon just because of a lot of the triptychs, the kind of evolution. So it's not always one image, it's multiples over time from different angles. And I just felt like it fit perfectly for talking about something like advanced care planning, where it's always kind of different. And if you look at it from a different side or a different angle, there's a different answer. So hope it it makes sense to everyone else as well.
Yeah, that's really helpful. Well, I think if we talk about the evolution of advanced care planning and where it sort of even came from, I think if we look back sort of in the 1970s, 60s and 70s, when we started having all of these, they call life-sustaining treatments, like being able to put people on a breathing machine or on dialysis. And there were some really high-profile court cases in the 70s. Two that come to mind were young women who sort of were in situations where, they no longer had brain function and were sort of being kept alive. And the families sort of wanted them to, be able to pass, to die. It was their time. And they were sort of not allowed to, and it went to the Supreme Court, and all of these things happened. And that sparked in the early 90s something called the Patient Self-Determination Act. And that sounds amazing, right? It's for people to be able to determine how they want their care to go forward. And the initial thing was to create advance directives or living will forms. And the goal at that time, and the way that things were set up, is that they created these forms. And I will say that most of these forms were created by lawyers that had a bunch of legal language in them that would allow people to check a box about, if I were to die, do I want CPR to try to bring me back? Or if my lungs fail, do I want to be put on a ventilator? And I will say at the time, it took a huge effort of medical people and legal people and policy and the law to get this enacted. And I think that people pinned a lot of high hopes on, if we have this form and these check boxes, this will A, make sure that everybody gets the care they want no matter what, and B, decrease healthcare utilization costs, because all of these ICU procedures and things that people don't want will go away, and will save the US health system, and people will get exactly what they want. So fast forward over time, there were more studies that were done in the late 90s, the early 2000s, basically showing that checkbox form, if you just focus on that checkbox form, you don't have discussions, you don't do some other things, which we'll talk about, didn't increase people's ability to get the care that they wanted, and didn't decrease healthcare utilization. So all of these things that we thought advanced care planning was going to do. But I will say, this gets to some of the slides, I think maybe the next 2 or so slides that we have, that advanced care planning has evolved over that time. We've learned from research that a form in and of itself isn't going to do the trick. That a form without a discussion, without an understanding of why somebody might want something, without forms that expand beyond these checkboxes and really allow people to talk about what quality of life means to them. Otherwise, those things are really just meaningless, and they don't really prepare people or their family members for medical decision-making. So I will say that advanced care planning has evolved from checkbox forms to preparing people for communication and medical decision-making, and we can talk more about that. BJ, anything you want to add to that sort of evolution, or how you've seen that arc happen?
It's well, one thing to add now, I think we'll pepper in over some of these other slides. One is just to note this subject matter and specifically failed interventions to improve it have a lot to do with how palliative care was born. So for fun palliative care history in the 90s, the support trial by Robert Wood Johnson, but there's a lot of history around it. I'll just say for now, this subject matter gets sort of very much at the heart of why palliative care came into existence in some ways. And interestingly, because these interventions kept failing, and we kept coming back to the need for humans, not forms. But anyway, yeah, I'll leave it at that for now. Shall we move on?
Yes, I like that, humans, not forms.
Mm-hmm. Amen. Okay.
So, I mean, I think in terms of the reality of advanced care planning, and it looks like Sonia, maybe you put the definition of value here, which is nice: worth, desirability, utility, qualities on which these depend. You know, I think if we just look at forms, it's really interesting because the percentage of people who have completed these advanced directive forms have been stable at about 35% for like the last 10 years. And you can imagine they're much lower in certain communities and populations, and people who have experienced racism in our health system. In those individuals who report that, the rates are much lower, 10%, something like that. But when you look at things like having conversations, talking to your family and friends about what is important to you, that's increasing. And I would say that we've even found with COVID that those sort of kitchen table conversations are sort of happening more. So some people will say, oh, well, advanced care planning is failing because the amount of forms aren't increasing. But I might say that advanced care planning is working because there are more and more conversations, and this is becoming more of a norm that people are talking about.
Yeah, that's such a beautiful point. In a way, I note this when I was with you at UCSF in clinic, it was interesting to note the better I knew a patient and their family, the more we got each other, the less we needed the forms. So I'm not saying there's an inverse relate, like fewer forms is better or fewer completed forms is better, but there's just an interesting thing that they can obviate the conversations that you're pointing to is really where it's at. And those can obviate the needs of the forms. And I also love like picking up on Sonia's artwork here, like as we move towards a value basis of care, that's in the background here. Sort of what are the trade-offs? What's worth going for as you as a person? What do you value? And checking that against what's possible, checking that against cost. This is a well-intended process and well-intended forms that are meant to celebrate the individual's preferences and for them to assert their own values in a sense. That's much the idea. So anyway, more to pick up on this one here, Rebecca, or shall we keep chugging?
I think we can go to the next one.
Right on.
So I think this slide just reiterates, sort of this evolution of, planning. So we wrote a paper in Annals of Internal Medicine back in 2010. And I think the field is starting to sort of, again, pick up this momentum, talking about redefining what the planning is when we say advanced care planning. And again, really moving away from only talking about life-sustaining treatments like CPR, mechanical ventilation, being on a breathing machine, even though those things, may be important to some patients. But again, focusing that planning on the preparation, on, preparing people for communication and preparing people with the skills that they might need to make decisions, either for themselves or for someone else.
Amen. All right, shall I keep chugging?
Yeah.
Yeah, okay.
So I think we've talked about the conversations versus documentation, and I will say the documentation is still very important. We'll maybe talk about that in the next couple of slides and what are the different kinds of documentation and why it might be important. But I always say that the form is only as good as the conversations that go with the form. And as you were saying, BJ, there are plenty of patients, I sort of give the example that been called to many ICU family meetings, and you could have that family that, maybe the person has an advanced directive, but they've never talked about it with their family and friends. It gets dug out of a back drawer, it gets brought in, and people are like, I didn't know my name was listed on here. I have no idea why they checked this box. We never talked about it. I don't know what to do. And then you can have the family that says, I don't have a form, and this is really hard, and I really wish we weren't here, but we've been talking about this for 10 years, and I really know what is important to this person. And then you have people who have both, and that's wonderful. That's a wonderful combination. But just saying that both and I will also say this, sometimes all you have to go on is the form, and the form can sometimes be an anchor to start conversations. So I don't want to say that the forms are not useless, because they're not. They can be very important pieces of information, but the two together are really the best of both worlds.
Right on, especially because, or including because people change their mind over time.
Yep.
It's not an inert, you make a decision about your wishes at the end of life, and then there you off and you're done. This is, in general, we tend to change our mind, especially as we move through illness and get weary from the treatments, or at some point death can start looking like an okay thing, and we want to get out of the way of it. Whereas 10 years ago, we might have said, hell no, I'm fighting it every two, So anyway, the point here is this is a process over time, and we get to change our mind. That's welcome. But all the more reason to keep up with your documentation, because if your documentation only reflects what you thought a few years ago, but not updated conversations, well, then it can get real tricky real fast.
And I think that's where the healthcare, where healthcare has gone wrong. They've thought about it as this one and done.
Yeah.
So we come in, you check off this box 10 years ago, it's in the chart. Ooh, wash my hand, like we're done. Don't have to talk about it anymore. And I think people feel that way too. It's like, oh, I've already done all my stuff. Talk to my lawyer. I got all this, and I don't have to talk about it again. Yeah. But so important, BJ, because it's exactly what you're saying. Like our lives change, our relationships change, our health changes, and our preferences. We're human. That's just what we do. So it's really important to kind of update them.
Amen. And healthcare changes. I mean,
Healthcare
new
changes,
treatments,
yeah.
new things become.
Exactly.
So it's dynamic. It's a work in progress, just like we all are. And this needs to be treated as part of that work in progress. Okay. We'll keep on moving until you tell me otherwise, Mama.
Okay. Yes, the form. So I think sometimes this can get confusing. So I'll just run through really quickly what these are. And I'm actually going to start with the Advance Directive first. So there are things that people can do. It's always best to talk to a medical provider or your medical care team. But these are things that people do and people sign. And that includes the Advance Directive and Living Will. And then there's things that a physician and in some states a nurse practitioner signs, which is the DNR and the POLST. But if I start with an Advance Directive, I'll tell you a little bit at the end of this talk about some of the Advance Directives we have, but not all of them are the same. Some Advance Directives look like those checkbox legal forms written by a lawyer, hard to understand, and there's a checkbox about CPR and breathing machine. And that's about it. Then there are Advance Directives, like our forms, Prepare for Your Care, and the 5 Wishes that focus more on values, goals, life goals. What does quality of life mean? And so I think when looking for an Advance Directive, you might want to look for one of those that let people, do that. The Living Will, so an Advance Directive allows you to do 2 things. It allows you to name what we call a surrogate decision maker or a proxy, or the person who would be your advocate if you couldn't speak for yourself. And it allows you to write down, again, wishes, values, preferences, hopefully what quality of life means to you and things like that. In California, people use Advance Directives, and it includes both of those things. In some states, every state in the country has their own laws about Advance Directives, and some states split those 2 things up into 2 different forms. One, they call it a durable power of attorney for healthcare, and 2, the Living Will that lets people write down their wishes. So in California, we combine them into an Advance Directive, and in some states, they're separate. Then there's the DNR, which is Do Not Resuscitate Order, and POLST, which is a physician's order for life-sustaining treatment. We had a DNR order for a long time in California. It's still legal, but the state has moved to POLST. In many states, I don't know how many states are represented on the call today, but the POLST is in different iterations in many states across the country. It's usually a bright pink form, and it is something that's filled out by a physician, and it's an order. And that's important because It's mostly focused again on those check boxes about CPR, mechanical ventilation. But because it's an order, if somebody shows up to the hospital with it, it's supposed to be what they call durable, meaning somebody has to honor that. And if you call 911 and EMS comes to your house and somebody has this bright pink form on the refrigerator or next to the bed, and the paramedics see it, they will follow it because it's a medical order. An advance directive is sort of like, you could think about it as a blueprint, strong suggestions. I would say for the surrogate decision maker, that's usually fairly legally binding, whereas the wishes maybe could be interpreted differently, especially if the form is old. But an order is an order, and that will stand unless a surrogate decision maker stands up and says, nope, they've changed their mind. We don't want that anymore. So hopefully that sort of describes that a little bit. I will also say this one last thing, and I'll turn it back over to you, BJ. The advance directive is really, and again, if you're focusing on and using advance directives that talk about values, preferences, and goals, that's something that, again, that someone can fill out themselves with their families and can be done at any stage really of health or illness. So you might be a younger person, but you want to designate someone who'd be your advocate. Or you might have strong preferences about what quality of life means to you and you want other people to know that. You can do that at any time, all the way up sort of to the end of life. The POLST forms were really meant, they were created initially for very frail, elderly people at the end of their life who were living in nursing homes. That was the original cohort of people who were really had very short lifespans. It's been broadened a little bit over time, but you can think about, well, should I do a POLST or should I do an advance directive? I think most people can do an advance directive, and really it's talking with the medical provider about whether or not it's most appropriate for the POLST for you.
Right. So, also kind of a cue on our last slide too, when to pull these forms out or when to try to have these discussions over time, anytime your mind is changing. But, if you're living with chronic illness, which we can for many, many, many years. So as you go through that, say if it's a cancer, if all of a sudden, or when it becomes metastatic, when death comes into view, these are moments to kind of consider revisiting your forms, maybe locking it in more with a POLST form. So the rhythm at which to revisit these depends on what's going on with you and your treatment and your disease process. It does. I guess it doesn't really make a ton of sense for a healthy person who isn't really super clear on what they're willing to live with and not live with. A POLST probably doesn't make a ton of sense at that point. I suppose if you're really an absolutist and will never ever want the mechanical ventilation, never ever want any intervention, I suppose then okay. But I think we should all reserve the right to change our minds. Anyway, one more thing to say about the POLST, just like you were saying about the state specific. In some states, it's called a MOLST. In some states, it's called, I can't remember the list, but it's confusing in the US in this way. Every state has some panoply of these. They may be called something slightly different. Okay, maybe shall we move?
Yeah.
Question, sorry guys to interrupt before you keep going. There was just a question here that I thought we could just address while we're on this slide. Can you talk a little bit about like unexpected things like an accident or an aneurysm and how these forms might play into that or not?
Yeah, I think there's a reason why when, kids go off to college, they're asked about an emergency contact, right? So I think for all of us, again, no matter what age or stage of health, it's really important to know who would that person be that could advocate for me and who might know me well enough to know what my quality of life looks like. So I feel like, those things are important. I would say normally, it's a long story. All states are different. They're what they call default laws about who can be a decision maker. So if somebody isn't designated, who do they turn to first? California doesn't have those default laws, but I can tell you at the bedside, that's kind of what happens. So if you're that person's closest family member, or you have someone who's your closest family member and you want that person, chances are the medical team will turn to them. but can't always guarantee that. And if you want someone who is a friend, someone who might not be in that hierarchy, really important to complete these forms, because I can tell you right now, hospitals are not allowed to talk to people who are not written down on those forms if they're not in that default hierarchy order. So I think that's really important. And then again, you know, if an accident happens, let's just say like an aneurysm or something, you know, we really do turn to those forms, or that's one of the first things we look at to see, are there forms in the medical record? Are there documented discussions between the doctor and nurse practitioner, other people, social worker, in the chart that might describe what is important to that person? And what is the family saying? So we take all of those things into account when we have to sort of come together with the families and make some decisions. I hope I answered the question.
And then one other question while we're on this slide, can you clarify just again the difference between the POLST and the DNR?
Yeah, so the DNR, there used to be an out of hospital DNR, and it was only CPR mechanical ventilation. The POLST expanded some of those options to CPR, and then some other, they call it scopes of treatment. Do you want to go to the hospital? Do you not want to go to the hospital? And things like feeding tubes and artificial nutrition, hydration. Some forms have things like antibiotics. So the POLST just expanded it, and the DNR was just really focused on resuscitation.
And this is a good moment. We'll get to, at the end here, we'll point you guys to Rebecca's site, Prepare for Your Care. But that is a good reason to visit her site, is to kind of stepwise move through these things. We'll get there. But a lot of Rebecca's work has landed in improving how people can access these forms and these conversations and to generate these conversations. So we'll get there, but there's help. All right. I will say one more thing. Oh, what was that?
Oh, no, go ahead.
I was just going to say, back to that, you know, I think through the Patient Self-Determination Act and HIPAA laws, I think I've heard stories anyway of, you know, when you're 18, you're, you know, legally an adult. And I've heard stories of, you know, college kids who were injured and ended up in a hospital, and family members would call in and sometimes meet with, I'm sorry, we can't tell you anything because this, you know, your 19-year-old or 20-year-old hasn't designated anybody as a representative or a proxy. That's a kind of a terrifying thought, I'm sure, for any parent.
Mm-hmm.
Practically speaking, Rebecca, do you see that as a real issue, or is that sort of the letter of the law versus spirit of the law?
There's a letter of the law and the spirit of the law. But, you know, so I can tell you, you know, there are many patients who end up in our ICU and are what we call unrepresented or unbefriended, meaning there's no one around that is sort of knows they're in the hospital or can step up. And then we do a lot of detective work to try to find any sort of, you know, what we call next of kin. And if we find a next of kin, we reach out to them. But I think it's when you want someone to be your care, you know, your advocate, who might not be your immediate next of kin, I think that's when it gets really important that you think about that and write it down, even if you're young and healthy. And there are many people who don't want their parents contacted or don't want certain family members involved in their care. And I think that's when it becomes important to do it.
Right. Okay. So practically speaking, we can expect even a young person, a young adult, that if you're a family member, that you're going to get information. It's really most important that these documents are in place when that person doesn't want a family member involved or wants a friend to be the kind of go-to person, when you want to upset that sort of natural next of kin assumption.
Mm-hmm.
Yeah. Okay.
Yeah. And I would say too, even if you want the next of kin to do it, whether you write their name on the form or not, again, what we see is that people in their mind say, oh, my husband, wife, you know, sister, brother, whatever, will just do it. And then they never have a conversation with them. Mm-hmm. And then that person's left on the hook. Like, I don't know what to do. Maybe if we skip to maybe slide 9, where it says being a proxy. I want to come back to this maybe at the end if we get through our slides, because I'm sure a lot of people maybe have some questions or have been in this situation. Having been in this situation myself, being a proxy or advocate for someone else is probably one of the hardest jobs that anybody will ever have, especially if you care a lot about someone. I'm tearing up, just thinking about some of the decisions that I've had to make for people. And if we don't prepare them, it's just too hard. Mm-hmm. So, I mean, I really think one of the biggest things that we do in advanced care planning is preparing our loved ones. And I'm going to talk about in the next few slides some of the data that shows that that's really the heart of the matter of advanced care planning. We can prevent suffering and distress on our loved ones if we start doing this now.
Right on. Well, why don't we jump in exactly into that stuff?
Well, why can we go to the next slide? Because maybe we can talk about just to let people know, you may or may not have seen things in the New York Times. There have been several articles that have referenced this opinion piece. And it was sort of, I would say, hard for many of us in the field, because the people who wrote this are really the leaders in palliative care, started the palliative care movement. But there was an opinion piece that was written in JAMA, Journal of American Medical Association. And one of the quotes from that, the upshot was that despite the intrinsic logic of advanced care planning, the evidence suggests it does not have the desired effect. Many clinicians may be disappointed that promoting conversations has not improved subsequent care as hoped. And just to say, I wanted to bring it up because, again, you might see things in the news and articles about this. There's a lot of I would say, discussions going on in the advanced care planning field. And I think the upshot is that when people talk about advanced care planning, we're not all talking about the same thing. We're not all on the same page. When these authors, and having talked to them, talk about advanced care planning, what they mean is that checkbox form. When I talk about advanced care planning, I talk about focusing on the human piece of people, quality of life, what's important to them, preparing surrogate decision makers. And even the authors who wrote this totally agree with that form of advanced care planning. They just don't call that advanced care planning. Mm-hmm. To me, it's advanced care planning or life planning or whatever you want to call it. Mm-hmm. But just to say that I think these things are getting sort of, overlapped and messed up. And unfortunately, it's confusing. I'll just tell you, it's confusing a lot of people. It's confusing health systems. It's confusing funders. It's confusing researchers. It's confusing clinicians. We were really excited because we were trying to expand at UCSF a program on advanced care planning focused on quality of life, what quality of life means to people in a particular department, which I won't name. And it's a department that normally wouldn't be interested in this stuff, and they totally were. And we were moving towards that. And then they read this opinion piece and they called me up and said, so should we stop asking people about what's important to them? Mm. So just to say, something that I think can remind people that advanced care planning is not just a form, it's all these other things and worth doing. And if you go to the next slide, this gets to some of the data I wanted to say. And again, if we want advanced care planning to save the healthcare system and to make sure that everybody's wishes are honored in every single situation, that's not going to happen because a form can't do that and even a conversation can't do that. But when we looked at high quality research studies, the highest quality you can get are randomized control trials over the past decade, across the board, every single study that looked at whether or not it decreased surrogate anxiety, depression, PTSD, that's post-traumatic stress disorder, complicated grief, and caregiver burden, 100% across the board, advanced care planning helped those things. There was only one study that looked at clinician distress, but it also helped that too. So when we think about why are we doing advanced care planning, again, I think this is really the main reason.
Mm-hmm. I'm so glad you brought us to this. And it's such a good case in point of how medicine with good intentions can complicate just about anything and everything. But yet underneath there is often a through line of something really important and really good happening. Anyway, thank you. This is a very helpful slide. Did you want to go back to any of the other ones, or shall we keep on
I
moving?
think why don't we end with just the last two on prepare, and then I'd really love to open it up to the group.
Beautiful, Rebecca. Okay, yes.
So I think you can go to the next one because I pretty much talked about some of those things. So this was the so as BJ was saying, our team sort of developed this online program called Prepare for Your Care. Really the crux of it are the fact that it kind of walks people step by step through these 5 steps of advanced care planning, like choosing, your advocate or your medical decision maker, deciding what matters most in your life and for your quality of life. We made sure it was easy to read. And I think the cornerstone are these videos that show people how to do something. So for example, this says how to ask somebody to be your decision maker, or how to ask doctors the right questions. Because we were finding when we talked to the community, people were saying, well, like, I know I'm supposed to ask somebody to do this or fill out this form, but I don't know how to do it. So we wanted to actually have it be very practical to show people how to do it. And then we'll end on the last slide here. This gets to the easy to read advanced directive forms that we have now for all 50 states in English and Spanish, and a growing number in Chinese. These are different again from those check boxes only, because we have a lot of things that focus on values and goals and what is important to you in life. And, is your cat, like BJ's cat, is that really important to you? Your pets, your family, your hobbies, the things that bring joy and meaning to your life. That's what we think really are most important. And so that's what these forms focus on. And if you go to the website, they're free. You can download them. If you fill them out, this is the other thing too that's beautiful about it. If you fill it out and you create a username and password, let's just say that a year from now you change your mind, the website will save your information and you can go in and quickly change it all up. You can also just download them and just do them outside of the website, but hopefully that's a helpful resource for people.
That's so good. I'm so grateful to you for doing this work, Rebecca. It's been very helpful to a lot of people I know. Did you just say too, I know there are groups like My Directives or others at Vinca, there are others have sort of vaults, secure vaults that are HIPAA compliant and all that stuff, where your advanced care directive can live. So no matter what hospital you're in, if they go to, there's somewhere that they can access it. Does Prepare for Your Care do that, or do you link into vaults, or how does that work?
Yeah, so the vaults, it's interesting. That is a really growing part. Well, there's 2 things that I think are exciting. One, there are more like health information exchanges. And I would say that there's several hospitals that we're working with that actually don't want to work with these other companies because the states are actually setting up these health information exchanges, so that like right now I can look at somebody's advanced directive at Sutter or Kaiser or another hospital in UC without having to go to like another third party. There are some other third parties, like you're saying, that will take your information and then help you get them to hospitals, but really it's only the hospitals that contract with those companies. And some of those companies like Vinca is working with some states where they're actually working with the state registry. And in that case, things work out really well. I don't know what states they're in, but that can be a good, for those states where they are there, then that could be a really good thing. We currently don't work with third parties, but are trying to work with third parties. And so we're open if people have suggestions to let us know.
Beautiful, 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 Rebecca. It also makes a point of how much of this is a legal process as much as a medical one or anything else. There's a lot to navigate here, but in here is a sort of a simple kernel of how to use state and protect your own wishes for care in a complicated system. Okay, Mama, that's so good. Shall we cut to questions, guys?
Yeah, let's do that, because quite a few have come in while you guys have been going over the slides. So I can just start with this while you're closing out the slide deck, BJ.
Sure.
This person said, I am interested in how to create a greater degree of specificity in advanced directive, and also what those areas of specificity might be, given I haven't gotten close to death yet.
Well, I think it depends about what kind of specificity you mean. There are definitely advanced directives out there that will say, if you were in a coma, would you want, these 5 things? If you were in an accident, would you want these 5 things? If you had dementia, would you want these 5 things? And again, I would say that the field has maybe moved away from, what we call like the menu checkbox version, again, because at the end of the day, those things could change, and maybe some of those treatments could get you over the hump or whatever. It really kind of comes back to like, what does quality of life mean to you? And what are the things that you're willing to live with, and what are the things you're not willing to live without? And I think understanding that, and like, again, what brings meaning to your life is important. So I'll give you an example. One of my patients basically said, the thing that is most important to me is that I can, talk to you, hang out, take care of my grandkids. And that is the most important thing to me. And if I can't do that, really, life is not worth living to me, because if I can't have that important, interaction. And then when he had a stroke, we wrote that down in his advance directive. I wrote that in my medical note. When he had a stroke, we maybe didn't know, does he want a feeding tube? Does he not want a feeding tube? Does he want to go for this procedure or not? We didn't know any of that, but we knew that this thing was most important to him. And he sort of basically lost brain function, and essentially would have been in a situation where he would have been bedbound, unable to communicate, unable to understand information, or, so the family made different decisions based on what we knew was most important. So I hope that helps.
Okay, great. The next question here is, how much does the CMS requirement that advanced directive forms need to be part of a patient's medical record drive the institutions to get patients to fill out those forms?
Yeah, so I think that's one of the arguments that people have used about advanced directives, that, as BJ, you were saying that we, sometimes health systems take a good thing and then they twist it and make it not so great. I think this drive to only complete advanced directives is not the way to go. But I will say this: having CMS have that allowed us to get our foot in the door for health systems to even care about advanced care planning, because before that they didn't. And I'll just give you an example about UCSF. So UCSF realized, okay, we're going to focus on the forms because that's what CMS is doing. But then, hey, what do you know? We realized that if we count other things, like designating a surrogate decision maker, writing goals of care conversations in the medical record so that there's narrative and text about that person, that counts too. They went from just the forms to something that they call clinically meaningful advanced care planning, which has transformed advanced care planning in the UC system. Would that have happened if we had our foot in the, didn't have our foot in the door? It would not. So I don't think we should take our foot out of the door. I think that we should just move the door, open it a little bit more to make it more broad. And there are people working on both ends of that spectrum, closing the door and some people trying to open the door.
Oh man, we're getting so many good questions. Okay, next up is, do you have any resources for those who have a strong family history of Alzheimer's or dementia and want to prepare for future care?
Yeah, so our easy to read advanced directives have tons of space for people to write whatever they want to write about dementia and what's important to them. There are dementia specific advanced directives. I'm trying to remember, the person's last name is Gastor, Gastor, at the University of Washington. And they have advanced directive specific or dementia specific advanced directives, but they're not legal forms. They're just sort of worksheets that you can use. But I've talked with him, like, people can fill out that worksheet and slide it into an advanced directive and it still will be considered part of that form. But like I said, our form has like space that people can write out a whole narrative about what's important to them and if they got dementia, what they want to do.
And those dementia or otherwise, those little details can be so good besides just the big crass movements of mechanical ventilation or not. But in our book, where you so kindly helped us, Rebecca, hopefully you'd have time to get to the story that you told us in that book, but we call this care and handling instructions. Are you a side sleeper? Do you like coffee? Little things like this can really help orient people's care. One of my favorite gets at your question about what is advanced care planning. One of my favorite sort of advanced directives was a woman who told me her father just came down. He wanted to be able to watch the Boston Red Sox games. And when he couldn't watch those, that helped orient the care decisions she made. That was a kind of an advanced directive. That was a detail that actually had consequence too.
Yeah.
So I'm so glad for that space you leave for those kinds of details. Okay, Sonia, back to you, girl. Questions?
Yeah, lots of them. Okay, so this one says, does an advanced directive reduce the chances or intensity of family conflict at the time when the healthcare agent is making the difficult decisions on behalf of the person who is ill?
It depends. So some studies show that it does, because it definitely decreases burden and distress and things like that. And I think when you could think about if there's nothing, I mean, I'm one of 5 kids, and I can just tell you, if my mom didn't have some of these things written down, we would be at each other's throats. And I've seen that as a geriatrician, and a palliative medicine physician, I see that all the time. I think it definitely helps, because it can help people instead of just pulling things out of the air. It's like, okay, this is what somebody said in their own words. And I will say that some families are dysfunctional. And I think people thought, oh, if I just have this advanced directive form, it'll fix dysfunction. And it doesn't fix dysfunction, but it definitely can help when the, chips hit the fan and you're trying to figure something out. You at least have something to go on. And I would say too, getting back to that surrogate, if that surrogate is the person making decisions and they have something in writing that says, this is what my loved one wants, and you have other family members who are attacking them or telling them that they shouldn't do that, the medical system can back that surrogate decision maker up. You've empowered that person to follow your wishes by having it in writing.
And that gets at one of your points earlier, Rebecca, which is really key. If some people look at that, picking a proxy as sort of an honor, like who, my mom, I want my mom to be my proxy because I love her so much and she's so great. Well, my mom would be a hot mess in a medical decision-making situation for me. So she probably wouldn't be the best proxy, the best surrogate decision-making. So especially, moving off my family for a second, but especially into heated or dysfunctional or multi-pronged family, naming that proxy, or even 1, 2, and 3, you can list them in order, can be a way to include people will be hurt if they're not included, but you can set up something of a pecking order. When there's a stalemate, someone has to make the final decision. Yeah, it can be very, very helpful to pull things through. It doesn't necessarily feel good. It can be chaos, but it can be effective.
And I will say too, things don't go smoothly when the person who writes the advance directive doesn't talk to all of the family members and tell the other family members, this person's the person I chose and this is what's important to me. And it goes like so much more smoothly if everyone was like, yeah, Dad told us that. We know you're the decision maker. I don't agree with you, but I remember he wrote that on this form. So I think, again, just doing the form and not sharing it with everybody who might be involved in medical decision-making, that's like the key point to kind of close the loop on that.
Right on. Okay, Sonia, what else we got?
Yeah, so many. I mean, this is just evidence of how confusing it is. This person said, how often should I update my advanced care directive? I completed it upon diagnosis, and my hunch is that my wishes may change as my condition changes.
Yeah, I mean, I think it's one of those things like, like our insurance, we got to like renew it every year. I think it's a good idea to, dust off just look at it. If you still agree with it every year, then you can just leave it. But then, things may change. I think other things they talk about, I can't remember if it's 4 or 5 Ds, but like divorce, good time to maybe change your advance directive if your partner is like listed on there. The death, like a death in the family, that might make you change what you're thinking. I can't remember the other Ds. Diagnosis, like a new diagnosis, or if your health changes, things may happen to you. Family member might go into the ICU and you're like, let me rethink that. Or you might go to the hospital and you might think to yourself, I would or I would not be willing to do that again. So I think when major things happen, it's a good time to dust it off. And if things are kind of going along stable, once a year, just take a look and see if anything has changed.
Great. Okay, this next person said, I haven't pressed for a prognosis with my oncologist, but I would like to talk with him about my advance directive. Is this a conflict?
Well, I guess it depends upon if you want to know your prognosis or not. If you don't want to know, you don't have to know. That is your right to basically say that you don't want to know your prognosis. It does make it a little bit harder for the clinician to sort of talk about what medical treatments, and again, they think might be most appropriate for you. But I would say too, this is the other thing, on our advance directive, there is something that allows people to write down whether or not they want to know this information. So if you're the type of person who's like, I don't want you to talk to me about my prognosis, you can write that on the advance directive, and then other clinicians will see that. But if you don't, you can still do other things of advanced care planning. You could still designate your surrogate decision maker, your advocate. You can still talk to your doctor about like, hey, this is who I am as a person. These are the things that I do in my life that basically bring joy and meaning to me. You can talk to that back to your clinician and to your surrogate decision maker. You don't have to talk about specific medical treatments. You don't have to talk about your prognosis. You can talk about what you're an expert on, which is you and what brings your life meaning and purpose and joy.
Next one, this is probably for a lot of people. Any advice on how to best approach these conversations with aging parents who you will be caring for, but they have not demonstrated that they are comfortable having these discussions?
I get asked this question a lot. And to be honest, we got new grant funding. So we have Prepare for Your Care. We're creating something called Prepare for Their Care. Because I get asked this question all the time, and we just didn't have enough funding to create the sort of sister program, but that's coming out at the end of this year. So keep your eyes peeled for that. But it's going to do exactly what you're saying. Videos that show, how do I bring this up with my family members and friends? How do I get them to start the conversation with me? So keep your eyes peeled.
What about those things like Go Wish? What are the other games that can kind of provoke these kinds of conversations?
Yeah, there's something called the Hello game, which I really like, and Go Wish. They're very similar. The cards, they're like a card game, and each of the cards have like values and wishes on them, and you can ask people like, hey, do you want to look at these cards? And you kind of sort them and put them in order, and it can be, I think that's a great idea, BJ. It's a great way to sort of get people talking without actually asking them directly. The other thing I'll say is that there's a story that I have about a patient of mine who had metastatic prostate cancer. And it was very elderly, and I kept trying to have these conversations with him. He wouldn't do it. I mean, I had like 10 meetings with him, and he would not talk to me about it, and tried to help him with advance directive, and he just wouldn't do it. But then his brother, who was his surrogate decision maker, died in the ICU from prostate cancer. And he couldn't talk to me about himself, but he could talk to me about what he thought about his brother's situation. So we all have situations of family members, what they went through, or even something you saw on the television. Like, oh, do you remember that movie where that happened to that person? Like, what do you think about it? Or, my, Aunt Sally, like, was, she went through that really hard time. Like, geez, you were in that situation. What would you do? And having that kind of conversation about somebody else's experience sometimes makes it easier to bring things up.
Right on. Yes. And sometimes it can be a time for self-disclosure by you discussing your wishes. Sometimes that can kind of be a thing to provoke and respond to. Again, with some degree of a safe abstraction, you can get farther.
Absolutely.
Okay, next up, this person said, with no family and friends to be my advocate, how do I best protect my wishes if I end up in a situation where I'm in the emergency room or ICU and I'm alone and unable to communicate?
Yeah, well, just to say to normalize this for you, many people are in that situation, and it's okay, and you can still advocate for yourself. So I think, again, for you, I think filling out an advance directive would be really important. And again, you can get them for free off of our website. And then I think once you have them, making sure that they're sort of in many places, that they're, I would say, even though we have these health exchanges and people are starting to get advanced directives, not all hospitals are part of that. So if you're in an area and you're like, ooh, I get my care here at this clinic and over here at this hospital, you probably want to make sure that both those places have the form. And, keeping, a form with you or taking it with you to the hospital can be really helpful. But if you have a primary care provider, making sure they have a copy, any friends or family, even if you don't want them to be involved in decision-making, having anyone else have a copy would be important too.
Great. This person asked, how can a patient link to a desire for physician-assisted death with an advance directive if they're in a state that allows it?
Yeah, that's a tough one. I'll say right now, so, let's take California or Oregon. There are no laws on the books in terms of what they call the probate code for advance directives that allow writing in that information about physician-assisted suicide where people would have to follow it. That being said, if you write those wishes down again in the free place in the advance directive, that's really important to you and all of the ways that might happen, it can help to be facilitated. However, I will say, if you, and BJ, you probably know more about this than I do, I think that you have to be able to make that decision on your own. And that's where it gets tricky if someone has dementia or if somebody has an accident or a stroke and can no longer make that decision on their own. Somebody isn't going to administer that medication to you. So I think it's still good to have it on the form because that really tells people pretty clearly about what's important to you, but it wouldn't be administered unless you could make the decision and take the medicine. And BJ, you know a lot more than I do.
And that's right. And these laws, we'll see how they're, again, another sort of spirit of the law, letter of the law. And these are in some amount of evolution, the waiting period, et cetera. But we still just can't, one wall that seems unscalable is how do you, if someone is not thinking clearly, to follow their guidelines to end their own life starts feeling really off. And I don't know how we're going to scale this one, but like your point, even if we know at some point when that person was thinking in a clear way, this was their wish. Well, one thing we can do with that is that can still be a very helpful guide. We can't actively hasten that person's death, give them a medicine that ends their life. What we can do though, at that point is very clearly get out of the way of death, which is, I think, a really important thing. So next time we got the pneumonia, we're not going to the hospital, et cetera. And usually if someone's sick enough to be unable to make their own wishes, it's not long before death will show up and we just have to get out of the way of it. So that's sort of a consolation route that, practically speaking, works pretty well. Okay, Sonia, show we, gosh dang guys, it's already.
I know, we're at time. Rebecca, do you have just another quick moment? I figure we might as well get through one other question here, which I'm sure is one that lots of people are wondering about. Are general practitioners supposed to, or are they required to talk about and go over these questions with their patients? Mine has never approached me about this, and I have been repeatedly brushed off. Thoughts or advice?
Well, I'll just say as a primary care provider myself, there are a couple things that get in the way. One, there just is not enough time. So all the things that have to be done and check medications and deal with people's questions, and there's people in the waiting room. I know, I figured out a way to do it, but it's really hard for people who it isn't in the normal thing that they do. Number two, I think clinicians aren't necessarily trained to have these conversations, so they don't know how to start them so that they can do it in a busy clinic setting and start the ball rolling. I will say this though, we learned in our randomized trials that if people sort of go to our website, they learn some things on their own, they fill out their advance directive, they were empowered to then go to the clinician and say, hey, I filled this out, I want to talk about it. And then the clinician, I can tell you, because we did these studies, we're like, oh, thank God. Like, I was afraid to bring it up, but now they're bringing it up to me. And oh my gosh, you just did so much more work. So we don't have to have a 40-minute conversation, but I can definitely have a 5-minute conversation with you, even if we need to have multiple conversations over time. So just to say that, like, you know, people can be empowered to start the process, and starting that process actually helps clinicians continue that process with you.
If that question, if I heard right, if you've tried this and your doctor is refusing to go there with you, boy.
Maybe change your doctor.
Yeah, that's how it's gonna go. I know that's kind of easy for us to say and hard to do, but wow, if you're really presenting explicitly with, here's my form, I want to go over with you, and they're saying no, wow, that is cause to look for another doctor.
The other thing too is, again, I work in a very busy primary care, and I understand the pressures on people. It's harder than ever, I think, on clinicians, to be frankly honest. If you call ahead of time and say, I want an appointment to only talk about my advance directive,
Great tip.
or is there a social worker at the clinic that could spend the time so that I can go over this advance directive with them? It's kind of can be a team sport. So that's another thing to try.
Beautiful, beautiful. Yes, great idea. Okay. Shall we cut to recording the rest of them, or what do you guys think here?
Well, I mean, if Rebecca, it's up to you. As
I have maybe like 5 more minutes.
Okay, perfect. Let's just do one more question, and then I'll
Okay.
address everything else over email. This one is just interesting because it's about a ventilator, which I thought might be important. So I'm not sure if I should say no in all circumstances to a ventilator or not. I'm inclined to say no, but my oncologist said he recommended not to say that because there might be some circumstances when it could save my life. How do I make this decision?
I'm going to let BJ take this one first.
It's really, really tough. This is where you can mark the sort of in between. I'll give ventilation a try under certain circumstances. This is where it's really nice to have a relationship with that doctor, because it gets down to what's medically possible. And that's very hard to proactively state. If you're X, Y, or Z, well, then you've got X, Y, or Z risk or ventilation will work in such and such percentage of time. It's not that clear. So this gets back to best sort of compromise might be to check the sort of middle way. Like, I'm willing to attempt resuscitation if it has a reasonable chance of bringing me back to a state that I value, where I can speak, or where I can eat for myself, or whatever. You can name that. If there's a hope that ventilation will bridge you to that, great. You can state those, you can stipulate that. And this is where it's really, really key to have a conversation with the clinician, so they're sort of armed to know when to push and when to stop. But it's really tricky. I don't have a better answer than that.
And, on our advanced directives, you'll see there isn't like CPR, no CPR, mechanical ventilation, no medical, there's an option that says, I want to try life-sustaining treatments, but if my condition gets worse and there's little hope of getting better or living the life I value, then I want to stop. And maybe that's the middle ground that might be right for you.
Yeah, contextualizing the answer. I think these things are very clear. If I never want mechanical ventilation or intervention, or if I always want you to try everything possible, those extremes are kind of absolute and kind of easy in a way. This middle way, which requires context and judgment, it's all the more important that you state who you are. So there's a chance that the cure, the treatment can suit you, the person.
And maybe we can end on this, because I think it's a really important point. As clinicians, we ask people, do you want this treatment or not? But the most important thing is the outcome of that treatment. So if the treatment extends your life and the treatment improves your quality of life, well, of course. But if the treatment might extend your life but greatly worsen your quality of life, then why would you do that, right? Or cause harm or pain, or you go through all of that and you still have limited life left over. So I think when you're talking to your doctors about this, you can say, like, okay, this is the treatment, but what is the treatment going to get me? What will my life be like? What will it look like after this treatment? Because that's really the key point.
Mm-hmm. Right on. Wow, beautiful. Let's end, like just to say, let's end on that point. And Rebecca, thank you so much for staying late and for being
Yeah, thank
with
you,
us.
Rebecca.
Extremely helpful. I could never talk about these things in such detail without you. So thank you, and thank you for for your care and prepare for their care. That's very exciting. So thank you,
Well,
guys.
it's so nice to be here. So nice to see you, BJ.
Mhm.
Nice to hang out, Sonia, and thank you everyone who's on the call.
Absolutely. Thanks everyone for being here. Have a good weekend.
Thanks, guys. Bye.